Are there thousands of lives to be saved simply through listening to the voices of those new to healthcare? This graph is from Simon Sinek. He explains how many corporations lose touch over time with why they're doing what they're doing, and so they fail. Is patient safety failing because we lose touch with why we do what we do? What we do in healthcare is turn up every day to do the best job we possibly can. Yet why we do it should be to provide the best in patient care. But are we? Does the following initiative reveal a deep-seated issue with the culture of healthcare?
After heart disease and strokes, medical error has been reported as the third biggest cause of death globally. The exact figure is difficult to estimate because error reporting in healthcare lacks transparency. But mistakes made in hospitals are leaving patients worse than when they went in. A group of medical staff decided enough was enough and began to agitate for change. Communication errors have been identified as the root cause of the majority of mistakes. Staff in operating theatres can work with hundreds of different colleagues between multiple hospitals, and their faces are covered, so in the midst of an emergency, precious seconds can be lost when clinicians don't know or can't remember the names of their colleagues, which can lead to lack of accountability, wrong equipment used, wrong drugs administered, and so on. To improve communication and reduce mistakes, the answer was remarkably simple. To immediately identify individuals and their roles, we began writing our names and roles on our scrub caps. It was a simple act which changed the culture of the theatre from anonymous to collaborative. Suddenly, it was easier to coordinate, to be more accountable and efficient. With the help of a hashtag, the idea began to take off. Medical staff globally joined in. Some even started printing their own name caps. The world sat up and took notice. What started as a simple idea among a bunch of so-called rabble-rousers has grown into a game-changing movement which is saving lives around the world.
Names are the sweetest and most important sound in any language. When we hear our name, our brains become activated in unique and specific ways. On hearing our name, we focus on it despite the noise and conversations around us, a phenomenon known as the cocktail party effect. And research has shown using names in healthcare is associated with increased trust, work engagement, and clinical improvement. Knowing names and roles is a non-technical skill, essential for optimal teamwork. Yet staff work in many different hospitals throughout their career, and the realities of modern hospitals are that rigidly assigned teams are a rarity. Further, the number of combinations of staff coming together to manage an acute event can be staggering. Introducing one another is an integral part of the surgical safety checklist. However, studies indicate, and the experience of many is, that while this box is always ticked, the actual process is less commonly performed. Even when it is performed, a study at Imperial College London demonstrated at the end of a theatre list, 25% of surgeons didn't know the scrub nurse's name, and almost 30% didn't know the anaesthetist's name. Not surprising when we realise humans are poor at remembering names. One way we've tried to overcome this is by writing names on whiteboards. However, the information is often incomplete and not updated as teams change. Also, whiteboards don't move as staff move. Better staff identification may have prevented this event. The anaesthetist believed it was a nurse qualified in checking who handed him the blood. However, it was a theatre orderly. The blood hadn't been checked, and the patient died. And after a series of adverse events in New South Wales, a Garling Inquiry 2008 stipulated all healthcare staff wear badges which display their name and role in large clear font. Unfortunately, in theatre, name badges are often covered by sterile and other gowns. So for the most part, we're unidentifiable, to the detriment of communication, teamwork, and ultimately patient care. This is the hierarchy of intervention effectiveness, a simple diagram showing in many respects how human factors experts see safety. They understand how we interact and that we all make mistakes. We can't change this human condition, however we can change the conditions humans work within. The people-focused interventions we've relied on in healthcare, warnings, alerts, policies, human factors experts consider less effective. Greater emphasis is placed on the systems we interface with. A reminder at the point of care will be complementary to, and also be more effective than, a checklist. So welcome to the Theatre Cap Challenge. Internationally, we're in continual collaboration, delivering data to support what is really an obvious improvement to patient care. So far, it's been endorsed by the Australian Society of Anaesthetists and supported by the European and American Societies of Anaesthesiology. But as I'm sure you're aware, it's by no means universal. Why not? There doesn't seem to be a problem with the initiative. Is it something else? Are we, those who've been in healthcare the longest, actually the problem? Well, what is our greatest fear in medicine? Hurting people, not being good enough, and when we make a minor change for the better, we might have to accept that we've been hurting people, even killing people for years. Cognitive dissonance describes the pain of accepting ego-dystonic facts. It inhibits an open, rational cycle of process improvement. A disturbing but very natural ego-protective attitude occurs where staff reject innovations that make their carefully honed skills less relevant. Senior clinicians may actively oppose or denigrate methods which are safer or more successful, not just for themselves, but for their learners and the systems as a whole too, in part because the innovation makes their own deaf skills less important. Healthcare management utilizes top-down hierarchical structures. These structures are extremely efficient when used in simple environments. They harness loyalty and professionalism and maintain conformity and accountability. However, the level of understanding of frontline issues decreases the further up we go and the further removed we are from the front line. Yet from the front line it appears that much of the work produced from above focuses on people-focused interventions, writing policies and guidelines, telling frontline staff how to do their jobs properly. Over the 90s, healthcare saw an almost exponential increase in the number of administrators, more groups producing more guidelines, yet creating a bureaucratic quagmire through which we struggle to deliver any really beneficial frontline change. So how is change resisted? Through using obstacles, like the C word, cost. However, writing a name on a hat costs nothing. Also, after 2 or 3 years, using reusable name and role hats works out cheaper than disposable ones. Another obstacle, show me the evidence. And when it comes to name and role hats, a bit absurd if you think about it. Show me the evidence that displaying one's name and role makes it easier for others to recall one's name and role. Evidence-based medicine is not designed to disprove basic science. Using it in this way is inappropriate. We've gathered the evidence anyway. A study performed in the UK demonstrated increased staff name recall from 42 to 85% and increased name and role introductions from 38 to 90%. Simulation studies from Stanford University show greatly increased team efficiency and closed-loop communication. Patients like the idea. They find it helpful and reassuring. They want us to do it. And the vast majority of frontline staff want to do it too. Interestingly, in this survey, there was overwhelming support from nursing and medical students, those new to healthcare. Yet the support was least from those who've been in healthcare for more than 20 years. Do we lose touch with why we're doing what we're doing the longer we're in healthcare? Those who've been in healthcare the longest have the greatest influence and are perhaps heavily represented in this laggard group. The laggards work to stop initiatives from crossing this chasm of change. Even when cost and evidence can't be used, other obstacles will be put in the way. Infection control. Perhaps the easiest way for staff to display their name and role in theatre is on reusable hats. Again, it's absurd, but I've experienced infection control being used in hospitals which already allow reusable hats, as if having one's name on the hat magically contributes to increased infection rates. All available evidence to date, and there is lots, demonstrates no difference in surgical site infection rate when comparing disposable versus reusable hats. In fact, disposable bouffant hats may represent a greater infection risk because of the pore size in the material. If you're concerned those in charge don't acknowledge the infection control data yet and don't want to upset them, you could always do this. Given cost, evidence and infection control don't stand up, what other obstacles have been put in the way? Within Australia, ACORN standards are often quoted. We've collaborated with ACORN, who point out they don't prohibit reusable hats but reference Australian standards for laundering. So we found the references. They don't relate to theatre hats, in fact they specifically indicate that headwear is excluded. Given the ACORN standards have negative impact, it's wise for us to challenge them. So what sort of negative impact is there? A 20-theatre hospital using disposable hats will discard over 100,000 hats every year. These hats are made from viscose, a substance whose production is particularly harmful to the environment. Also, there's the financial cost of disposing so many hats. And in inhibiting perhaps the easiest and best way for theatre staff to display their names, patients are left at unnecessary risk. Given name and role theatre hats are better for communication, teamwork, staff engagement, theatre efficiency, represent an environmental and cost saving, are beneficial to patient care, and there's no perceivable downside. Is there something else we're missing which is getting in the way?
To answer that question, we set up a hidden camera experiment to see if this woman would stand up at the sound of this tone, simply because everyone else is. You might be thinking you'd never go along with this. Or would you? After just 3 beeps, and without knowing why she's doing it, this woman is now conforming perfectly to the group. But what happens if we take the group away?
Elaine, please.
Okay, now she's alone. The crowd is gone and nobody is watching her, except our hidden cameras. What do you think she'll do? She's now conforming to the rules of the group without them even being there. Now, watch what happens when we introduce another outsider who doesn't know the rules.
For a noon appointment.
Have a seat and they'll be out in just a couple minutes.
Great,
Thanks so much.
Why was it?
Everybody was doing it, so I thought I was supposed to.
Think she'll teach the new guy what to do? We kept the cameras rolling as more unsuspecting patients arrived. And slowly but surely, what began as a random rule for this woman has now become the social norm for everyone in this waiting room. Here to explain what's going on in their brains is Jonah Berger of the University of Pennsylvania.
This sort of internalized form of herd behavior is part of what we call social learning. Starting at a very early age, when we see members of our group perform a task, our brains literally reward us for following in their footsteps.
When I saw everybody stand up, I felt like I needed to join them. Otherwise, I'm like excluded. Once I decided to go with it, then I felt much more comfortable.
Conformity is how we become socialized, but it can also cause us to develop bad habits or repeat past wrongs.
And it's why even this rebel, who wasn't standing for any of this nonsense, eventually joined the ranks. And the only thing more shocking than seeing how easily conformity affects the way you act is that similar forces are subconsciously shaping the way you think right now.
We're very strong social conformists, challenge ingrained cultural beliefs, and we get very upset.
A group of scientists placed 5 monkeys in a cage and in the middle a ladder with bananas on top. Every time a monkey went up the ladder, the scientists soaked the rest of the monkeys with cold water. After a while, every time a monkey went up the ladder, the others beat up the one on the ladder. After some time, no monkey dare go up the ladder, regardless of the temptation. Scientists then decided to substitute one of the monkeys. The first thing this new monkey did was go up the ladder. Immediately, the other monkeys beat him up. After several beatings, the new member learned not to climb the ladder, even though he never knew why. A second monkey was substituted, and the same occurred. The first monkey participated on the beating for the second monkey. The replacements repeated until what was left was a group of 5 monkeys that, even though never received a cold shower, continued to beat up any monkey who attempted to climb the ladder. If you asked the new group of monkeys why the beatings took place, the answer would probably be,
"Well, I don't know. That's just how things are done around here."
I dare you, wear a name and role hat when next in theatre and see what happens. It's fascinating. I hope the response changes over time, but for some, it's been like this. Sometimes doing the right thing takes courage. Intimidation can be driven and perpetuated by top-down hierarchical frameworks. Frontline ideas from those who best understand their work environments are easily squashed. Within one of my own hospitals, we're still not allowed to present the name and role hat initiative. As the intimidation persists, so does the status quo. And unfortunately across the world, every day things get a little bit worse. Imagine for a moment training students to be the best they could possibly be at passing an exam, and then every day making that exam just a little bit harder. Over time we might expect to see an increasing failure rate like this, except this is actually the annual adverse event rate in the NHS. Every day our workplaces increase in complexity with new drugs, new equipment, and a constantly renewing workforce. The greater the complexity, the greater the risk of error. If the interventions we put in place to deal with these errors only further add to the complexity, more policies, more alerts, more forms to fill in, then we design our hospitals to increasingly fail. Estimating the magnitude of the medical error problem is difficult, yet there's little doubt it's big and upsetting, and at the moment it only appears to be increasing. We need to change. Yet what hope do we have of delivering change while at constant threat of being beaten up in the monkey cage? Well, to understand something is to free oneself from it. So step outside the cage. We understand. We're part of a rapidly developing framework which harnesses a faster, more agile way of delivering the interventions required for patient care to improve, which allows frontline staff, manufacturers, managers, system safety experts and you to work collaboratively and transparently, sharing information and driving projects to fruition to deliver the best in patient care. We're changing healthcare culture, realigning what we're doing with why we're doing it. As well as ensuring better staff identification, there's many other projects to see to fruition and many lives to be saved. And through working together, we'll create the best environment for patient care.